everybody. My name is Stuart Schlossman, president and founder of MS Views and News. We're here tonight for an MS Views Now event. And tonight's guest, we have Dr. Emily Reiser, and we are sponsored or supported for tonight's program by BRISTOL-MYERS SQUIBB, GENENTECH, and BIOGEN. And now going back to speaking about our presenter tonight, I'm going to take this off for a moment so you can hear me better. We have Dr. Emily Reiser. Dr. Emily Reiser is with the Tanner MS Center in Birmingham, Alabama, where she has been the medical director now for, wow, over 19 years. My gosh, you're making me feel very old. Just me saying that. That's crazy, right? So Dr. Reiser is here tonight to talk about multiple sclerosis and COVID-19 and the reaching rural America and underserved communities and so on and so forth. What we want to preference, though, is she's going to be speaking about COVID-19. And before Dr. Reiser begins, I want to let you know that she's going to be showing slides, and we're going to be doing this for about 35 minutes. And after the 35 minutes, I'm going to come back online, and we're going to take the questions and answers. If you have it, we're going to take the questions from you, and Dr. Reiser will provide the answers. That's better said, right? So I'm going to let Dr. Reiser take it away from here, and I'll see you back in a little while, okay?
Thank you, Stuart, and I really appreciate MS News and Views reaching out to me, particularly at this time, to talk about multiple sclerosis and what we've kind of learned together and what we need to be thinking about going forward. So the focus of tonight's talk is about coronaviruses. And, you know, this is a family of RNA viruses, and they're very interesting because they can cause respiratory illnesses in humans. And the name corona, people may not realize this, comes from the fact that this virus has many crown-like spikes on the surface of that. So they call it the coronavirus. And there have been many examples of outbreaks of infection secondary to coronaviruses that you may or may not be aware of. For example, the SARS, which stands for the Severe Acute Respiratory Syndrome, that occurred many years ago. And then there was MERS that occurred in the Middle East, the Middle Eastern Respiratory Syndrome, and then even the common cold. So coronaviruses had been here for some time. So COVID-19 has a unique name. It is a coronavirus, as I mentioned, like the other coronaviruses, but it has its own unique characteristics. So it's been designated as SARS-CoV-2, CoV-2. So when you read these papers and you see SARS-CoV-2, you'll know that we're talking about COVID-19. Now, this was first reported, as you recall, in the wet markets in Wuhan, China, back in December of 2019. And I don't think anybody really understood the extent of this until suddenly there was this declaration that we're now in a worldwide pandemic. There's been a lot of speculation about, you know, how all this got out and how it moved around the globe, but that's going to be another story, and history will tell us what all really happened. But as of today, we're looking at, 113 million cases and 2.5 million deaths worldwide. So I've given this talk several times over the past 12 months, and these are really staggering numbers. And in the US alone, you're looking at 28,200,000+ people with COVID-19. And as you're well aware, there've been over 500,000 deaths, which is really a staggering statistic. So the source of COVID-19 viruses is pretty unique. And it's found in animals that we typically don't hang with, such as bats, maybe a cat, not so much our domestic cats, but bats and wildcats and camels. So you can now begin to see where these pandemics and where these problems have begun. And the virus, unfortunately, can mutate. And when it does, it can move from animals into humans. And that is what happened back in December of 2019, when the first cases showed up in Wuhan, China. So COVID-19 transmission is strictly airborne by and large, and it travels in these very small respiratory droplets following a simple cough, sneeze, talking within 6 feet, and it can be 15 minutes of exposure. So just a simple sneeze in a room can infect everyone within that small space. And so close contact, touching, shaking hands anything that occurs like that with an infected person could induce transmission. And there's been a lot of discussion about touching surfaces, and I think that's still true. I mean, when this first started, everybody was like wiping down their groceries and all this kind of stuff. But I do think that the secret is not so much, you know, the touch, but when that touch is then introduced into a surface on our face, like our eyes or our mouth or our nose, that's where trouble begins with these small respiratory droplets. So the incubation for COVID-19 is approximately 14 days. As I mentioned, the entry point is going to be in the mouth, in the oronasal pharyngeal pathways. And this particular virus, this coronavirus with these many spikes, this crown, it's going to attach back in the mucous membranes in the nasopharyngeal cells. And once it does, it can begin to mutate within those cells, and problems can begin, particularly in susceptible hosts, where that virus can then expand into the lower respiratory tract system and cause a severe acute adult respiratory distress syndrome. So the initial COVID symptoms, and this is by and large more or less what we typically hear from patients that have MS, are going to be the fever, the shortness of breath, a dry cough, little soreness in the throat, some body aches and chills, fatigue. Gastrointestinal symptoms have also been reported up to and including diarrhea. But the more interesting thing that occurs with COVID, and this first came out of some data in Italy, is it gets back into an area where it can cause loss of taste and smell. And so that has been something that has been very eye-opening for patients when they first realize that they've been infected with this in the absence of fever. So the initial event, as I mentioned, this virus, this RNA virus that's like coated with these spikes, it binds to an epithelial cell in the nasopharynx, and it attaches to a specific receptor called angiotensin II receptor. And from there, that's where the trouble begins. So the course of the COVID infection, you know, kind of is occurring in approximately 3 separate stages, depending upon the host, the person who has been infected. As you recall, the majority of patients, you know, can be totally and absolutely asymptomatic, but that's going to be in that stage 1. If the viral replication, you know, reaches a critical mass, it can then kind of morph into a stage 2, you know, where patients have more symptoms. You know, they're beginning to get fever, they're beginning to get the muscle aches, the body aches, the dry cough, and what have you. But then something very unique happens in the immune system. And the reason this is so important is for MS patients is we know what the immune system is, and we understand, you know, about autoimmunity, but in a unique host, suddenly this hyper-inflammatory immune response occurs, and that's what pushes this COVID infection into this severe stage 3, where patients end up in ICU on ventilators. So this is a cartoon depiction. Over here on the left, you can see in the upper left-hand corner, that's the lung. That's the bronchial tubes. The windpipe is kind of in the blue, and those 2 lobular things on both sides are the right and the left lungs. And then in the lung, there's a small little area called an alveoli, and that's where there's transmission of oxygen and carbon dioxide in the small space alveoli. Well, what happens is when the virus latches into the back of the throat on the angiotensin receptor, then it replicates in those epithelial cells, and it moves down into this lower tract, into the alveoli. And there's this very unique inflammatory response where cells begin to move to that space because the virus is now in that space. And these inflammatory cells called leukocytes, granular cells, and lymphocytes get into that space. And some even travel outside of that little blood vessel at the bottom and get into that space. And there's this release of this other substance called fibrin. And as a consequence, all of this collectively leads to this thing called the cytokine storm. And there's like a little tiny tornado down there. But what cytokines are is they're proteins that are being secreted by inflammatory immune cells in our immune system. So it's the cells themselves that are secreting these cytokines, and these cytokines have very, very inflammatory, dangerous characteristics when they get into these spaces. And this is a computerized depiction of what acute respiratory distress syndrome looks like. So you've got the lungs on the right and the left, and you've got the airway coming down. And then what you have is you have these small spaces down there in the white, where the alveoli are. And this is where this inflammatory response is occurring. This is where this cytokine storm is occurring. And these are individuals that require, you know, mechanical ventilation. And this has been the biggest scare and why this whole thing has caused so much worry over the past 12 months. The next picture here is a real live X-ray. And you can see here that in the dark white, you should see the cardiac silhouette. That's the heart. But when you look left and right, those spaces should be black. That's airway, that's air. But when you look there, those spaces are totally whited out. And you can now imagine that there's no airway exchange in those alveoli. That cytokine storm and that inflammatory response is now impaired the exchange of oxygen and carbon dioxide across that membrane. And these are patients who are severely affected. Their oxygen levels are terribly low. They're on life support. And this is the ultimate terrible, you know, manifestation of SARS-CoV-2 or COVID-19. So as I mentioned, you know, COVID-19 in and of itself, I mean, it can be a mild, just, you know, upper respiratory tract infection with a cough, you know, a fever, some body aches and what have you. But when this inflammatory response occurs in a very susceptible host, and I think that's one thing we'll talk about, it creates this downstream problem where cells in our immune system that are supposed to be just kind of helping us to stay healthy kind of go ballistic. And when they do, they begin to secrete all these inflammatory proteins called cytokines. And that cytokine storm can not only cause just the acute respiratory distress syndrome, but that cytokine storm can cause multi-organ failure. And from a neurological perspective, we're seeing strokes, seizures, encephalitis, and a whole host of very unusual and very profound neurological sequelae as a consequence of this cytokine storm. So what are the COVID risk factors? You know, we've all been asking this question over the past 12 months. And what we've learned is this, because there's been a registry where we have been collecting data, not only in the United States, but all around the world. And what we're beginning to see is there is a pattern to who is at risk for severe COVID and multi-organ failure and acute respiratory distress syndrome. And we know for a fact it's going to be the elderly. And that's going to be defined as anyone over the age of 60. And it has a lot to do with this concept called immunosenescence, where our immune system is just more vulnerable the older we get. The second is in African Americans and Asians. And there's been this big disparity, particularly here in the South. You know, I hail from Birmingham, Alabama, and we've seen an extraordinary number of African Americans who have been severely affected by COVID. So it's just an interesting concept, but it is certainly a risk factor. Anyone who is immunocompromised, and that doesn't mean just MS, because people think because I have MS, I'm immunocompromised. MS in and of itself is not a risk factor for COVID. It's someone who has an autoimmune disease who's immunocompromised, and we'll talk a little bit more about that. It's also going to be more prevalent in transplant patients and in cancer patients who are receiving chemotherapy, where there's a reduction in their immune system. I want to touch briefly too on obesity, because this is now a really big topic. If your BMI is greater than 30, you are definitely at greater risk for COVID than a subject who has a normal BMI. And also individuals with comorbidities such as diabetes, congestive heart failure, patients who smoke, Smoking is bad, everyone. I'm just going to reiterate that. Liver disease, sickle cell disease, and so on and so forth. So this is what the COVID-19 mortality numbers kind of look like. And we have to carve this out in the context of just coronaviruses and what we know. So with the original SARS outbreak, the estimated case fatality rate was about 10%. When MERS came online, it was about 34%. Now, and that's to compare with just the seasonal flu, which is 0.1 to 0.2%, and based on the CDC. Now, Ebola, as you recall, was just catastrophic with a mortality rate of 50%. But if we look at the next slide, I think what we're learning is that the mortality here, the case fatality in COVID, has been this moving target. As you recall, when everyone first heard about this, people were like, nah, everyone was in a state of denial. No, nothing's going to happen. Everybody's asymptomatic. They're getting a cough or cold, whatever. But then you can see from March 14th of 2020 kind of what happened as this kind of, blew up. And if you look at the United States, down here in kind of this blue line, we were as high as maybe mortality rates in the 6th percentile. But now you can see as we kind of come out into February, that these rates are somewhere down in around 2%. So, and this curve may continue to move. We're learning a lot about COVID, but I think that this is a fascinating curve, and you can find this at the CDC. So COVID therapeutics, I'm not going to talk a whole lot about this. I think this was the hot topic back, when we had the spike of really severe COVID, all the hospitals were full. Everyone was talking about, what do you do? What do you do? What do you not do? And then ultimately, we got FDA approval for an antiviral therapy, remdesivir. A lot of that work was done actually here at UAB. And then convalescent plasma, monoclonal antibodies, so on and so forth. But we're not going to spend a whole lot of time on therapeutics because I want to focus on the big story. And the big story are vaccines. And everyone's heard about Operation Warp Speed, and people kind of get concerned about the timeline on this. But it's extraordinary that we now have 3 FDA-approved vaccines for COVID-19. I mean, this is extraordinary. The first 2 that came online were the Pfizer and the Moderna. And as all of you know, this has a lot to do with a specific technology. It's called messenger RNA technology. This technology has been around for a long time, and we'll talk about that. These are both given in 2 parts. Pfizer, 2 injections, given 3 weeks apart. Moderna, given as 2 injections, 4 weeks apart. And then we the other day, just got an FDA approval on Johnson & Johnson, which uses a different technology. It's called a viral vector technology. But the unique thing about this one is it's just 1 injection, and it doesn't have to be stored as carefully as the Pfizer or the Moderna. So it may be that vaccine that's going to have an application in countries that don't have the ability to deliver and to maintain Moderna or Pfizer. Next slide. So these are the 3 types of coronavirus vaccines that have been in development. As I mentioned, we have 2 that are FDA approved that have to do with mRNA technology, and 2, the viral vector technology, but there is a protein-based also. I think the thing that we have to think about is that these technologies have been around for a long time. And I think when patients or just the community in general first started hearing mRNA, it just sounded scary. It sounded like genetic or something weird. But remember, once the human genome was cracked, then the scientists had the ability to know exactly every gene that's creating every protein, not only in our body, but in other, pathogens. So that's what's happened here. So these are all the different types of corona vaccines in development. And I'm going to talk specifically about the 2, the mRNA and then the vector-based viral vaccine. So this is how mRNA vaccines work. So we know from the beginning of the talk that the coronavirus means crown or many spikes, And we know that that spike protein is what's attaching, to that ACE receptor and causing that viral replication in those cells, and then replicating and causing all of the problems, not only with just the mild cases of SARS, but with ultimately that acute respiratory distress syndrome. So what the scientists have done is they've taken that spike protein and they've been able to sequence the RNA, and they've been able to then coat that RNA up with a lipid coating, and it's in a little particle called a nanoparticle, a tiny little nanoparticle coated in fat, coated in lipid, packaged up in a vaccine that's kept at a certain temperature. And then that vaccine can be put into the arm. And once that goes into the muscle, then that RNA can trigger those cells to actually manufacture the spike protein on the surface of a normal cell. And then the immune cells down at the bottom, you can see those little red antibodies, can then come and recognize that spike protein with a lock and key specificity and then create memory. So the next time someone is exposed to COVID-19, SARS-2, then they will automatically have those antibodies come and neutralize the effect, the downstream bad effect of the COVID virus. So that's how mRNA vaccines work. Now, non-replicating viral vectors have been around for a long time too, and this is a little bit different. So basically what's done here is you're trying to figure out a way to get a little bit of a genetic code, DNA in this case, into the body, into the host cell, so that you can get the host cell to make the spike protein. And the way you do it is they take a virus called an adenovirus, and adenoviruses are responsible for the common cold and for the pink eye. So, kids with their snotty nose and pink eyes typically have adenoviruses. So you would say, well, why would you use a virus? That's scary. You could get really sick. Well, this adenovirus is acquired from chimpanzees. It's mammalian. And this particular adenovirus does not replicate when it gets into a human. So the scientists can take a fraction of DNA, put it into this adenovirus vector. So it's now like a little vehicle, and then it can be put in a vaccine, injected into the arm. The viral vector can get into the host cell. Remember that the viral vector doesn't replicate. And then it can induce the host cell to make the spike protein. And then we get the antibodies and the specific lock and key immune response that we need to create memory. Now, with RNA and viral vector vaccines, the big question is, how long does this protection last? And we don't know exactly, but the feeling is that there will be months of immunity following the protocols for the mRNA viruses and for the non-replicating viral vectors. So you might ask about vaccine efficacy. And these numbers are a little misleading because we have to remember in clinical trials are designed, to get an effect. So you're going to have a group of patients on a placebo, which is kind of a fake treatment, fake vaccine. And then you're going to get people on a vaccine, and you're trying to see how good that effectiveness is when you administer something that's a placebo and something that's actually the real vaccine, whether it be mRNA or viral vector, what have you. And when you look at these numbers, you have to remember that the Pfizer and the Moderna trials were kind of back early on in the COVID, right? And then things kind of changed, and then we had some variants, the African variant, the Brazilian variant, and that's kind of when J&J, they were involved in their clinical trials. So when you look at the numbers, we can honestly say that Pfizer and Moderna are highly effective. But when you look at J&J and you say 66%, you say, well, gosh, that's terrible. No, it's not terrible. It's actually really effective, particularly in preventing severe COVID deaths. So it's really effective in reducing severe COVID. And as I mentioned, it doesn't have to be refrigerated like the other ones, and it is a once vaccine. So, but that is the data. The papers are available, and the CDC has all this on their website. So I get this question in the clinic all the time, Dr. Reiser, is there aluminum in that vaccine? Is there this in that vaccine? What's in that vaccine? Well, I mentioned a little bit about the nanoparticles and the fat, but these are some common ingredients in mRNA vaccines. Polyethylene glycol is in there. Now, and you say, what is polyethylene glycol? Well, it's in toothpaste and a lot of things. It happens, polyethylene glycol is in one of our interferon products. So it's kind of a macromolecule, something that's used to make things a little bigger and long lasting. So polyethylene glycol, salt, of course, the mRNA sequence that the scientists manufacture, other fats, sugars. So those are more of the common things that are in mRNA. And remember, on the adenovirus, the common thing is it is an adenovirus. So that's something we have to be mindful of. So where does this lead us when we think about the greater picture of COVID-19 and multiple sclerosis? Because I've had some patients that literally, and you can share your stories as well, that have not left their house for the past 12 months. And this has been really scary, particularly down here in the South. So we'll talk a little bit about what COVID-19 really looks like for patients who have MS. And I think I mentioned that MS in and of itself is not necessarily a risk factor for COVID. But if you happen to have MS, and most of you on the line tonight do, or you're a caregiver, these are the risk factors. If you have progressive MS, whether that be primary progressive MS or MS over a long period of time that has progressed, meaning you're walking with a single point cane or bilateral assistance, you probably are at greater risk for having a more severe case of COVID than someone that has relapsing MS. The second thing is age. We mentioned that just as a general risk factor, but for patients with multiple sclerosis, age of greater than or equal to 60 is important. Men with multiple sclerosis for some reason. African Americans with multiple sclerosis. We talked about this disparity, particularly here in the South. We're seeing a lot of that. Disability, that goes hand in hand with progressive MS. So an expanded disability severity score of greater than 6 means that someone is having to use bilateral assistance for ambulation. That would be 6.5. So EDSS score is greater than 6. Multiple sclerosis and obesity, and that's something that we really need to focus on because that's something that can be managed. But the BMI greater than 30 is definitely a risk factor if you have multiple sclerosis and you're overweight. Also comorbidities of diabetes and heart disease. And finally, and we'll talk about this with a little more specificity, multiple sclerosis, if you are taking certain immunotherapies that deplete B cells, or you're on immunotherapies that induce immune reconstitution, where we're taking down T cells and B cells and looking at them coming back. So those are the therapies that we would be more concerned with kind of going forward in terms of just how we manage those patients. Next. Okay, so MS treatments and COVID risk. I'm getting 1,000 phone calls a week about this. I mean, the low risk are the platform therapies. Those are the therapies that go back to 1993. The interferon, the GA, that stands for glatiramer acetate, and the Aubagio, the teriflunomide. Mild risk, Tecfidera, only because there is a chance that it can sometimes lower your lymphocyte count. The class of drug called S1P modulators, they sequester these immune cells in your lymph nodes. So that's going to be your Gilenya, Mayzent, Zeposia, Tysabri, extending the dose. Your moderate risk is going to be your TYSABRI given more frequently. So there are some neurologists that are extending the dose of TYSABRI from 4 weeks to 6 weeks. So that's something to be considered. And then the higher risk are going to be those B cell depleters, the ones that are taking down the B cells that are coming out of the bone marrow. So that's going to be your Ocrevus, your Kesimpta, the new Novartis drug, and then the cladribine. And I think I left out Lemtrada. That should go on there as well. So the National MS Society has come out with a consensus statement. And this is not just somebody sitting around, just tweeting out something. They basically commissioned a panel of the best experts in the world. MSologists, immunologists, neuropathologists. These are the smartest people in the space. And they put their heads together and they looked at mRNA technology, and they looked at viral vector technology. They looked at patients with multiple sclerosis on all disease-modifying therapies, and they came out with a consensus statement, which is all patients with MS should consider taking the COVID-19 vaccine. COVID has turned the world upside down. The vaccine will give you, the individual with MS, the opportunity to be healthy and safe. It will give you the opportunity to start getting back into some semblance of what we used to call normalcy. So that's the recommendations in the consensus statement. They also say that the vaccine does not increase the risk of relapses. I get a lot of questions around that. And that the vaccine doesn't cause progression. And finally, the vaccine can be taken safely with all current disease-modifying therapies. And we have a lot of them, so I'll mention them next. All right, so MS therapies and vaccine considerations, no issues with interferon, GA, Aubagio, Tecfidera, TYSABRI, really. So you can take the vaccine with all of these drugs. If you have some kind of, partial immunosuppression, which we see with S1P modulation, which is Gilenya, Mayzent, Zeposia, you could have partial immunity relative to someone who's a normal subject, let's say, for example, that's not taking one of these drugs, but you can still safely take the vaccine. It's just that the 95% or the 94%, you can't say with impunity that that's going to be the efficacy number if you're on a drug that holds lymphocytes into the lymph nodes. So, but the recommendation is always take the vaccine 4 weeks prior to starting these. If you can, if you're on maintenance therapy with these particular drugs, it's safe to go on and take the vaccine. And finally, timing consideration really needs to be considered with our B cell depleters and with our immune reconstitutors. Again, 4 weeks prior to initiation, if you're a newly diagnosed patient. And then if you're on maintenance therapy, the vaccine should be pushed out to about 3 months after the dosing, but always best if it could be done at around 6 months, if that's possible. So COVID-19 prevention, we gotta still do this. If nothing else, y'all, all of these measures have had a huge impact on our health and well-being. I mean, the incidence of influenza is down. So washing our hands, we don't want to touch our eyes. We want to cover our mouth when we're coughing or sneezing. We want to stand back, clean our surfaces, wear our mask. I love Stewart's. He said it was thin, but I thought it looked really cute. And adhering to quarantine when exposed. That's really important because we really gotta prevent the transmission. And I want to talk about this because, our governor is going to have to make a decision on Friday whether or not we lift our mask mandate. And this is what we know about masks. So if you look at the top, you got this girl on the left who has COVID. She's not wearing her mask. And she goes out there and sneezes on some sweet girl over here on the right who's wearing her mask. So the transmission probability is 70%. And then in the middle on the left, you got these cute girls. And this girl now is wearing her mask because now she learned that, she's a COVID carrier and she needs to wear it. And she's out and about. And this other cute girl decides that she really doesn't like the way it looks with her outfit. The transmission probability is 5%. But when you get to the bottom where the carrier is wearing the mask and the healthy control is wearing the mask, the transmission probability is 1.5%. So the masks have made a huge difference. They really have. And I hope and pray that our governor, maintains our mask mandate, because I think it's going to be important. We certainly will be wearing masks in the clinic and recommending that all MS patients do as well. So these are my final thoughts as it pertains to multiple sclerosis and COVID-19. Wow, it's been a journey. We've learned a lot in 12 months. And what we've really learned is that we're right now, at a point where we can make a difference in this pandemic, not only with the things that we've talked about, but with the vaccines. They're clearly safe and effective. The masking, the social distancing, the hand hygiene, all that's really important. Please stay vigilant. Quarantine, and please self-report, because the contact tracing is critical for us as a society to understand, particularly as we look at mutations and variants. We really need to understand the data management piece of this. The informatics is huge, so please report anything that you know is going on with you to your doctors. Don't forget the importance of exercise, because remember, that really alleviates stress, also keeps your BMI down, and it minimizes your risk of becoming obese, because that's a huge risk factor. And finally, I'm just going to share, a little statement that my mother-in-law used to always say when we'd always come in and just, complain and freak out and stress out about everything in the world. And God love her, she's since gone, but she would have, if she were here, she would say, "This too shall pass," and it will. So again, I want to thank Stuart. I want to thank MS News and Views. You guys are fantastic. The work that you do, getting the information out to the MS community, is just a wonderful mission statement. And I always appreciate you reaching out to me and including me in the process.
Thank you very much. Thank you. Thank you.
You're welcome, Stuart.
So firstly, I want to we got to give a great round of applause to Dr. Reiser. This is one of the best dialogues I have heard during this entire series that we began at the beginning of the pandemic. It's been an evolving series from month to month, keeping everything relative to what's going on. And of course, Dr. Reiser came in when there's just so much to talk about. And now with the vaccines out there as well, there's just that much more. But her slides were fantastic. I mean, we really need to thank her for everything that she did to put this together, to make it so that way you all can have better knowledge of what's happening. Okay, so real big thumbs up to Dr. Reiser. Thank you.
You're welcome.
Now going forward, we do have a lot of questions. All right, and I have them that from people who wrote in questions when they were registering for the program. And of course, we have many that are asking as you've been speaking. So I'm going to go back and forth a little bit, and then we'll level out and just take them from one place or another. So firstly, and I know you said it during the program, you've probably said a lot of these things during the program, but for those who missed it because people did come in late, some of these questions may have been already spoken about by you, but I would like you to just, repeat the answer anyway. The first one being, the one that everybody seems to be asking, is how safe are these vaccines for the MS community?
These vaccines have been studied, have been tested in robust clinical trials, have been administered to over 70 million individuals around the world. And these vaccines are safe. And I think it reminds me of the old days, Stu, when MRI technology first came out. They called it nuclear magnetic resonance imaging, nuclear. And everybody freaked out. And they didn't want to have one because it sounded nuclear. So it's going to rearrange something bad in my body. And then the scientists went back and they said, well, we'll call it MRI, magnetic resonance imaging. Oh, that sounds nice. Well, this is because the science and the technology had been studied for decades. And it was a game changer in neurology. And these vaccines and this science and this technology had been studied for well over a decade. And so now there was a translational opportunity to really come on board and test these in these trials where there were thousands of subjects, and to get this kind of effect in this time frame has been extraordinary. And I mean, I didn't have a problem taking the vaccine. My husband didn't have a problem taking the vaccine. And the consortium of individuals that the MS Society selected to study this are the most intellectually honest people in the world. And I'm confident in saying tonight on your program that the vaccines for COVID-19 are safe and effective.
So thank you for that answer. And I want to let everybody know I haven't told really anybody. I did get the vaccine, and I'm here talking to you. And I didn't grow another foot, and I didn't grow a tail. All right. And I'm able to speak with you all. All right. And my arm hurt like hell after the first one, and it was better after the second one. All right. I did feel a little lethargic the next day after the second one, but come 2 days later, I'm back to myself. All right. And, yeah, the fear of getting the COVID far outweighed the fear I had of getting the vaccine itself. So I want to let you all know that that I did get it, and you are the first ones that I'm telling this to. Okay. All right. Next question. We have a lot. People just typing away here. All right. All right. So from Yiki. Yiki wants to know, if someone sneezes close to you, are you saying that you can catch it when you have to be around the person, or that you have to be around them for at least 15 minutes before you can catch the germ?
I think you can catch it at any point in time, because this is aerosols. These are small little bitty particles, and I don't think you necessarily have to be hanging for 15 minutes.
Yeah, but does somebody have to be afraid that they could be around anybody that sneezes and get COVID? Exactly.
No. I just think that if you're in a place, okay, where you don't know who these people are and where they've been, and someone's sneezing, I would exit stage right. Okay.
Right.
But I'm not going to go into that place without my mask.
Right. But what about the person that might be sneezing and is wearing a mask and sneezing into their own mask? Now what?
Okay, so we saw at the bottom, there's still a risk of transmission if both people are wearing a mask. Now,
Right.
We don't have data on the double masking. I think that's kind of this new thing that's been floated, right? I don't think anybody's going to wear 2 masks, to be honest with you.
Well, I have.
Yeah, I mean, maybe if you're like playing or something, but it's going to be hard to enforce that. But I think that if there's still a risk. But if you have on a mask and you feel the need to sneeze and you're around other people and you haven't had your vaccine, you need to sneeze into your coat or something else, because there's still a small percentage that it could be transmitted. Sure,
I understand that.
Because of the aerosol.
All right. I hope everybody else does too. So, all right, next question. How will COVID-19 affect an MS patient? Is it the same for everybody? Is it really dependent on each person and their own immune system? How does that work out?
I think it's dependent on everyone and their own immune system and maybe what they're taking. But it's also, Stu, it has a lot to do with the genomics of that individual. There's a lot of talk about blood types and other things. But I will tell you what we've gleaned from MS patients just from these registries. Patients that are affected with COVID, not only do they get all those things we talked about, the loss of smell, the loss of taste or whatever, but I think for MS patients specifically, it causes this really weird fatigue, this strange fatigue, not just MS-related fatigue, but this lingering fatigue that lasts for weeks. And I also mentioned in patients who have, unfortunately, that full-blown cytokine storm, we're seeing strokes, patients are developing seizure disorders, patients are developing cognitive impairment. So there's a plethora of other things that even a patient with MS could be susceptible to having if they were to have a very severe case of COVID with a cytokine storm.
Okay, thank you for that. Next, from a person that asks, how safe is the new vaccine with Copaxone?
Perfectly safe with Copaxone. Copaxone is the brand name, okay, for the compound glatiramer acetate. I think I had it on the side. The slide is GA, glatiramer acetate. GA, glatiramer acetate, is a sequence of 4 amino acids, you know, the natural building blocks of our protein. Okay. So Copaxone or GA is about as natural as it gets. So there's no contraindication whatsoever for taking any of these vaccines that have been approved with Copaxone.
Okay, thank you. You know, just to round things out, because there are people asking about Moderna, we're asking about Pfizer, we're asking about the J&J, and we even have a person asking about AstraZeneca, even though it's not here yet. But the bottom line is do you recommend for MS patients on taking any of these vaccines, or are you siding more toward one than another?
I'll be honest with you. I think that we don't have data to say this one's better than that one, that this one is what you should take versus that one. I think based on allocation, if you have an opportunity to take a vaccine, you should take that vaccine. It's all about allocation and where you live and about distribution. We have people driving all over the state trying to get anything that they can get. So the safety is there. The clinical trial design and the reporting and the ongoing reporting of the data looks perfectly safe. Now, if you're on social media, you may be hearing all kinds of things about this and that, and I get it. I listen to patients every day, and I'm always an advocate for what the patient feels comfortable doing. I get that, but we have to be very mindful about all these things that are out there on social media, because we have to remember that if something's going to happen in association with a vaccine that's an adverse event, it's going to happen very soon after the vaccine. That's why they make you sit there for 15, 30 minutes, what have you. But these things that occur a week later, 2 weeks later, a month later, we don't know if that just wasn't an occurrence, because things do occur in all of us that aren't necessarily related to the timing of an immune response. So we have to be mindful of a lot of the things that people are talking about on social media.
Right. Thank you for that. All right. Will the vaccines affect patients that take an Ocrevus? I know you answered this already. I know you spoke about it before, but for all those that are using a B-cell therapy or anything similar, what can you tell them? Is it safe, again, about the different medications?
Absolutely. First and foremost, when you have those conversations with your treating physician, you want to be, assured that your doctor is treating you with the most effective therapy for the type of multiple sclerosis that you have, okay? B-cells depleters are highly effective, and they're given for patients with high active disease burden. Now, they do have the risk of causing a mild degree of immunosuppression, because you're basically killing B cells. B cells come from bone marrow. They come from hematopoietic stem cells. They're released into the circulation. And we basically give Ocrevus that makes them go away. And they start coming back at 3 months, and they're back at 6 months, and then we give it again. So theoretically, patients on Ocrevus are relatively immunocompromised. But at the same time, patients that are on Ocrevus are on this particular monoclonal antibody because they have a very active form of multiple sclerosis. So the worst thing the doctor could do would be get scared, take the Ocrevus away, and next thing you know, the patient is developing disability. So we want to maintain the disease-modifying therapy as scheduled, but we want to be mindful that during that initial 3 months of B-cell depletion, you probably need to be really careful about kind of getting out and going here and going there and doing this and doing that, okay? And we also need to be mindful that when you look at the MS registry that's being looked at relative to COVID, where all the doctors, we actually take these pieces of paper, I've got the name, off of it, but we take these pieces of paper and we type into this database what this patient takes, when their COVID started, what were their symptoms, was there a death, was there not a death, so on and so forth. What we found from this registry is that the highest numbers of cases of COVID have occurred in patients taking Ocrevus, okay? But they're not cases that led to death. These are just cases of COVID. They've had cough, they've had fever, they've had to quarantine, but it wasn't anything that made the doctors think that they needed to change the course of therapy, because the MS is so active that the patient needs this specific treatment therapy to keep the MS under control. But just be mindful that the vaccine can be given, and the timing of it is really the important issue.
Okay, thank you. We have a lot of questions, so I'm going to ask you just to shorten some of them a little bit, okay, if you can. But don't leave out all the important stuff, just shorten it up a little bit somewhere, right? All right, this question is one I've never seen before, and so I think it's great for whoever wrote it in. Should I be getting the vaccine? I just finished my last Lemtrada infusion in November, and my T4 cells are only at 73 out of 200. Would you recommend me getting the vaccine with this deficiency?
Okay, so, the consensus statement says that you could take this vaccine as early as 3 months. My hunch is it's not going to cause adverse events. You could certainly take it because it was back in November. But the sooner you allow the reconstitution, if you allow the reconstitution, you're going to get better immunity from the vaccine. So if you can hold off and you don't feel like you're high risk and everything's, going well for you, doing the hand washing and the masking and all that, you could argue for letting your T cells repopulate and then taking the vaccine.
Okay. Now, thank you for that. Now, the next one is asking, and this has been asked by many people, if they have a flare, an MS flare from getting a flu shot, can they expect the same from COVID vaccine?
Yeah, and it's the timing of the flare. Meaning, if you had a flu shot and you had a flare a week later, it may just be that you had a flare. It may be that it's not related to the vaccine. The flu vaccine is not a live vaccine, so it's just a conversation you'll need to have with your doctor. It's a risk benefit to all of this.
Right. Could it be possible that that having MS and having the hyperactive immune system makes some people with MS less likely that they'll ever get sick? Because some people, I myself included, how many times I've actually gotten sick in the last 20 years, I could count it in less than a half a hand. All right. So this is not my question. Another person is asking this, but what does the role of having a hyperactive immune system have for getting the virus or not?
MS in and of itself is not a risk factor for getting the virus. Very, very fascinating. Only if you have those things that we talked about. It's unique, like being old, being fat, being black, being disabled, being on a B cell depleter, being on an immune reconstitution. But just having MS does not make you more susceptible for getting COVID.
Yeah, no, this person was saying also that he or she knows others with multiple sclerosis that were exposed to people with COVID, yet they were never affected.
We just don't know, do we? We don't know.
No.
It depends on antibodies and testing, and we just don't know.
Okay. Is the number of underserved patients with MS high compared to the mid-socioeconomic MS population?
In terms of the vaccine?
I think in terms of, I really don't know. I don't know what the person's saying. It just stopped right there. So.
Okay, I do think, there is this disparity amongst African Americans. We're seeing that in the South. So there is this disparity. And, there may be this low socioeconomic or something, or nutrition, or there may be some other variables. People are looking at it, but the vaccines are, as far as we know, based on the science, are safe.
Okay. What is it about people of color that makes COVID-19 worse and their MS worse?
We do not know. We do not know. I know in the South, because, we are what we call the stroke belt here. Y'all may not understand that, if you live outside of Mississippi and Alabama and Georgia and going up to Tennessee, we have the highest rate of heart disease and stroke in probably anywhere in the world, probably. It has a lot to do with the nutrition and the obesity. And I mentioned that this obesity is a very important risk factor, and it may be it may all come back to that.
Actually, it's all that damn pork and gumbo that y'all eat.
That's what it is. I think too, the problem, in getting to the disparity, for the poor, when they go to get their food stamps or whatever, they're not allowed to get the healthy food, right? They don't have the option to get the healthy food. They have to get, the white bread and the stuff that it's just not healthy. So there's a disparity at a nutritional level. So the nutrition, the obesity, and all these things contribute to disease.
Wow. So how did something like that get changed? How do people address that?
Change has to start right here.
Sure. Okay.
Yeah.
All right. Well, that's something we could look at in the future. In the meantime, let me go back to the online questions. All right. Barbara has a good one. Can I get the vaccine at 10 a.m. and do my rebiff injection at 10 p.m.?
Certainly. But, if you're worried about that, remember, if you've been on interferon for a long period of time, you have an interferon effect. So it's not going to go away. So if you take your vaccine that morning, you have a bump on your arm, you kind of feel crummy, take your rebiff the next day and then start your cycle over 3 times a week from there. Does that make sense?
Thank you.
Yeah.
Does to me. All right. Tamara is asking, Tamara or Tamara, I don't know how to pronounce your name correctly, but I'm sorry. It's still spelled Tamara, however you look at it. Is the new Johnson & Johnson a live virus?
The virus is live, the adenovirus, but it's not a mutating virus. It doesn't replicate in the body. So that question has come up, but it's not a live virus like a virus that actually gets in your body and replicates. So it's yes and no, but it's just a vector. So the live part of it is the vector, but it can't replicate. So that's what makes it unique.
Okay. Diana is asking, would these vaccines need to be given annually like the flu vaccine?
There's probably enough evidence to say that, yeah, because, we don't know how long the protection's going to be. That's kind of where we are, right? We're just trying to get this pandemic under control, but it's conceivable that this effect may only last for several months.
Okay, that's true. Angela writes, how often will the vaccines have to be taken after the first 2 dosages? Annually, or is it possible? And again, this relates to what you were just answering, but like now they're talking about Pfizer doing a 3rd or a 2nd booster. So how does that work? And how soon would that have to be taken?
Yeah, so basically, Stuart, we would have to have the ability to check SARS-CoV-2 antibodies, right? And so that's where the science will go. We will have, a commercially available way to assess the level of the antibodies in our system. And then that would tell us going forward, at what point you would have to take a booster. And I think that's what the scientists are looking at right now.
Okay, thank you. All right, next. Next. Does the COVID-19 vaccine address any other health issues?
In terms of, I think it's genetically engineered to just deal with SARS, CoV-2. I don't know that it addresses a whole lot of other health issues. I think it's not designed to do that. I don't think that's what the question was in the clinical trials.
All right, next question. Thank you for that answer. Next question. How does the coronavirus interact with our immune system, which is already abnormal?
Well, what the coronavirus does, not in stage 1 or stage 2 necessarily, but in stage 3, it induces our immune cells that are already pretty active. It induces them to become hyperactive at the site of infection. That could be in the lung. Like I said, it could be in other organs. So it would induce a mega immune response at that site. Now, that doesn't necessarily mean that that person's going to have an optic neuritis or a transverse myelitis or an MS attack. They're going to have acute respiratory distress syndrome. So the immunology of it is the effect is going to be primarily at the site or in the organ where that hyperimmune response is occurring.
Okay, thank you for that answer. Are there any specific genes of people that have people have that cause them more likely to get COVID?
They're looking at that. We don't know, do we? Type A blood, certain genes, certain ethnicity. There's a lot of questions that still remain unanswered. And so if Stuart gives me an opportunity to come back 12 months from now and talk about this topic, everything I told you may be different.
That's
because
right.
I've given this topic, I've given this lecture multiple times over the past 12 months, and I can tell you it's a moving target.
That's right. That's right. Okay, next, what do we have? We have, if we have time later, we'll go back and we'll answer some of these questions that are being asked that are not about COVID, okay?
Okay.
Just to be fair, and we'll try to get some of them answered. All right, so going on to another one. Let's see, we have Linda is asking, how many days apart should I take my Avonex and COVID vaccine since they can both cause flu-like symptoms?
Linda, great question. I think we kind of alluded to that with the rebip. If you are on maintenance therapy with Avonex, which is interferon, you have an interferon effect. So missing a dose of Avonex is not going to alter the natural history of your course of MS, okay? So if you're going to take your shot, remember, it may be fine the first time. You may be asymptomatic. The second time, you may mount a greater immune response if you're doing the Pfizer or the Moderna. So you may not want to take your Avonex that same day. You may want to take it, 7 days later. And then start your sequence.
Sorry for cutting into you. No, keep going.
So just use your judgment. You can always, remember, still take your ibuprofen and your Tylenol and all the things that you're in, your hydration and everything that you're doing. But most patients that are taking the vaccine will take it. They don't want to take another injection on the same day. I don't blame you, because then you don't know what's vaccine and what's your MS treatment. So you could hold off, for a couple of days or even a week if you had to. You have an interferon effect. That effect is going to remain in your body for months. It's not going away.
Thank you. Now, just to be fair, I got to tell you all the kudos that people are giving, all right? And I'll get to that in a second. And then a few people are asking, since I brought it up about me having the vaccine, they wanted to know what DMT I'm using. And I don't know if I want to say it. I mean, I can, but just so you all know, though, even though I've been doing this for 12 months that we're involved with all this, all right? And I see and I hear all the doctors talking, like Dr. Rise is saying, about the no effect of doing the different medications. All of that, even I know it like I know what I'm missing my tie today, but I'm sorry for that. But I know it really well, those answers, right? And yet still, I was going for my Tysabri infusion yesterday. And the day before, I contacted my doctor and I said, is it safe for me to do this after I just got the vaccine? So, yeah, I mean, I already knew the answer, but I still had to ask, all right? And of course, he wanted to smack me in the head for even asking him. But yes, the answer is it is safe for you to do your medication and to do the vaccine, as Dr. Reiser said, and all the doctors before her. Okay? Just, if you have to leave a space, you leave a space. And the National MS Society is also saying, to space it out if need be, if you're using, certain medications. Okay? All right, now let me give you some of the kudos, and then we're going to get into more questions, all right? Carol writes, wow, thank you. This was the best dialogue I've ever heard. And then she also wrote, I can't find her other one. Oh, so how do you, nope, that wasn't it. But she did write another one, and I can't, oh, great job. This was the best. That was Carol again. All right, and then somebody else wrote, thanks for the information. Wasn't even considering watching, but as soon as I got connected to Wi-Fi, now I'm better and more informed, and this is great. Thank you very much. Thank you to Kimberly for that. All right, and we had another one here that I wanted to read to you. I got to find, oh, Deborah writes, excellent presentation. I took second dose of Moderna today and just feeling tired. So thank you for that, Deborah. And what else? Do we have anybody else that wants to say hi and thank you? There might be, but I'm still going through a lot of questions here. All right, so Jill is writing. Funny that I saying Jill because I mentioned at the beginning that Jill is a very common name, and that's why names are being mentioned. Jill writes, do you think the mRNA composition might be used in multiple sclerosis? That's a great question, Jill.
Okay, thank you, Jill, for asking that question. This has been floated, on the internet, this question. And some big-time scientific immunologists have kind of weighed in on this, which is, it's still too early to know. But this gives the scientists a minute to pause and to think about what other applications may be available when we look at not only autoimmunity, but cancers and everything else.
Great, thank you. Next question from, well, it wasn't really a question, but we'll address it anyway. Stephanie's saying that I'm a long hauler who has MS. So do you want to explain, please, what it means by a person being a long hauler? Doctor? In terms of she's going to wait it out? Is that what she's saying, or? No, I think, well, I really don't know, but so let's not think that it's coming from Stephanie, but what about those that have gotten COVID and are now long haulers with the COVID and have multiple sclerosis? What do they have to look forward to negatively?
Yeah. No, it kind of broke up. I understand what you're saying. If you've had COVID, we talked about, MS and neurological sequelae in COVID. We get that, but ultimately you will recover from COVID. And the recommendation is that you probably should still take the vaccine approximately 3 months after the initial infection, because it's going to provide more immunity, because you could theoretically be reinfected.
Okay, thank you for that response. Rachel is asking, does COVID vaccine taken when pregnant cause any ill effects on the fetus?
Okay, so that's, here again, some of that has been floating around here recently, and we do not have a registry with a statistical number that can tell us anything as of yet, but that data is certainly being collected. And here again, next time I come back, we'll have data. But, women who are pregnant have miscarriages and have other things that can happen, at a certain percentile. And we don't know whether some of these things are related to as an adverse event to a vaccine or not. We just don't have a registry that gives us what we call an N, a statistical N, a number where we can say anything at this point.
Okay. Thank you for that answer. Rainey writes, the MSs I know who are exposed haven't gotten it except me, but I was totally asymptomatic. Is it possible that our hyperactive immune system, again, are surprisingly protective? My neurologist says his anecdotals might support this. Your feelings are?
No. I don't think there's any evidence that supports the type of COVID that you got phenotypically. I don't think there's enough science or evidence to support that.
Okay. All right. Next. What do we have next? Sorry. I just wanted to look down and see if I had any more on paper before going back to here, but we'll go back to the screen. All right. Dana writes, could the RNA delivery mechanism of the COVID vaccines provide any new hope for methods for treating MS in the future? I think you just were asked that before, so I'll let you answer it again.
We certainly hope so. All these things have been tested in the lab. There's been no translational study, meaning, phase 2, phase 3, real world data to suggest that that's the case at this point. But I think the technology in general is just magnificent, and I'm sure it will be impactful in other disease states as we go forward.
Great, great. And for everybody that's on here tonight, please know that we'll be doing this type of program again next month and the following month and the following month and the following month. And as long as it's COVID, we will be doing MS Views now every single month until we are beyond COVID. And who knows, maybe we'll still talk about it and be in the series doing that as well. And the dates will change a little bit because like right now we're doing the first Monday of, what are we on? The first Wednesday of the month. Next month, we'll be doing the first Wednesday of the month, and then we're going to switch to another date only because CANDO, the organization, is starting a series that begins and will be taking place on the first Wednesday of every month. And we did not want to have our two programs bouncing off of each other and people not knowing which one to listen to. So we're giving way to the CANDO organization, and we're just moving ours to another date. Okay? So you will get the emails, though. I guarantee that. Okay. Next, Shelley writes, if you want to share experiences, I'm over 75 with relapsing. First shot was sore arm for 2 days. Second shot, fatigued and slept much of the next day, then fine. Husband has Parkinson's, had worse symptoms 8 days after the first shot and only 1 day after the second shot. Shelley, thank you for sharing that. And yes, I'm sure people would like to have answers from others as well. So if anybody else out there is listening and did get a shot and did have something that they want to share about their shot, I'd be willing to make that announcement as well. All right. Repeat question. Sorry about that. Repeat question. Sorry about that. Some person writing funny that they like me watching me double mask before, but okay, that wasn't funny. I'll do 3 if you want to make you laugh again. All right. Terrific talk, says Mary. Thanks for the time tonight. Carol wants to know what's the difference between MS fatigue and COVID fatigue. That's going to take me to a new question to ask in a second too. All right. First, if you could answer Carol.
That's an extraordinary question. You know, MS fatigue is not like I'm just tired, like if I took a nap, I'll be better. It's something, it's almost like this global fatigue affecting cognition. But for something about this COVID fatigue where patients really get an exacerbation of that MS fatigue and it lasts for weeks. It's not like, you know, I'm fatigued and for a day or two, you know, this lasts for weeks. So that's just clinical experience. I don't have any scientific data to back it up, but that's just what patients are sharing with me.
Okay, thank you for that. Now that's going to lead to a question that I'm going to ask you, and this is going to be a little bit more time consuming maybe. So for those that are long haulers, we've heard that many of their symptoms are similar to MS symptoms. So how will you, the MS neurologist, know when a patient comes in and they're complaining about their COVID symptoms because that they're a long hauler? How will you know the difference between them having symptoms of being a long hauler or having MS?
Okay, symptomatically, it's going to be impossible to tell, right? Because as clinician, we listen. We believe everything you're telling us. We take it to heart and we document that. But when you think about progression of MS, you have to think about this concept called NEDA, N-E-D-A, no evidence of disease activity. So for me, I would say, are you relapsing? And the symptoms of fatigue in that context don't always represent a relapse. Number 2, are there any changes on your MRI? That would be an easy thing to do. We could order an MRI. Number 3, I could just assess you looking for any changes in your disability scores. And I would know that by a 25-foot time walk or, you know, just by looking at you. So there would be ways for me or your clinicians to know if there's been a change in your MS. But insofar as the fatigue, long hauler fatigue, MS fatigue, that's all subjective at this point. We wouldn't have a way to really quantitate that.
Okay, thank you for that. Juanita is asking if after your second dose, you have an unusual reaction, who are you supposed to report it to?
To the facility that gave you the dose.
Do you know how hard that is to get in touch with?
It is hard, but you need to be persistent, even if you have to go back down there to the line and talk to the lady that's registering people. That needs to be reported. It's very important. Okay. You can always, you know, try to contact the CDC, but here again, trying to break into these big institutions and stuff.
Yeah,
but
exactly.
It's best if it can be reported at a grassroots level.
Okay. All right, great. Now, Barbara's saying thank you. Very informative information. Sonja is writing, Dr. Reiser, thank you for all the great information. I feel much more comfortable about COVID in general and the vaccines after listening with you. Carol writes also, thank you, Dr. Reiser is awesome. And you as well, Stuart. Well, thank you, Carol. But you know me too long, so you shouldn't be saying that. What else? Mary writes, terrific talk. Many thanks for some of your time tonight. Again, these are all kudos and lots of kudos here. Barbara, again, very informative, and thank you. And I hate to do this with you all, but somebody is challenging me to wear 3 masks, and I got to do this for a minute. And Dr. Reiser, while I'm doing that, if you can just put in your own, without any being prompted about anything, is there anything that you want to tell everybody that's online tonight about what remains of COVID and what they should be doing for themselves and their family?
I think the most important thing is just don't be afraid. I think fear has driven a lot of information over the past 12 months. I think that we have enough data now to know exactly how we should move forward. And you should remain on your disease-modifying therapy. You should not be afraid of the vaccine. You need to get to a point where you can get out of the house, where you can interact and you can socialize and you can begin to feel like yourself again. This can be done. But you're still going to have to do this for a while. I will say that. And you're still going to have to do this and the hand sanitizer and all that. But I'm very optimistic. I'm the most optimistic that I have been in quite some time since this first started.
Great. Thank you. And
You're
just so you know, there's somebody named Sherry or Sharia or something from Mobile, Alabama. And by the way, I'm wearing 3 masks now, all right? I have a K95 and I have 2 fabric masks on. And I can still breathe, everybody. All right. Amazing how everybody says you can't breathe in these things, but you can. All right. And I feel very, very comfortable right now, except my ears. I feel like a monkey the way I'm looking with my ears, probably. Right. But all right. So Sherry says, though, I was going to make a trip to you from Mobile to ask if it was safe. So, you know, let her know if it's safe for her to travel up from Mobile to see you, please.
It's perfectly safe. We're a hybrid practice. 80% of our work is telemedicine, telehealth, and about 20% is just really having to see patients at a time point. You can't just be an MS patient and not be seen by your doctor for years. You know, you have to come in at some point, and we have accommodations for that. So it's perfectly safe. Things don't look the way they used to look up here, but we've made the changes that are necessary to keep everybody safe.
Yeah.
And also, Stuart, we're going back to Mobile, aren't we?
Yeah, we're going to be back in Mobile. We're going to have, when MS Views and News gets back out on the road again, and I'm really, really hoping that that's coming soon because I so miss flying, all right? Really, really miss flying. But to go further with that, Dr. Reiser will be speaking in many locations throughout Alabama and in other areas of the South. My question box closed up, so I got to get it open again because there were more questions there. But yeah, we're going to have Dr. Reiser down in Mobile. And we're going to have Dr. Reiser in Montgomery, and we're going to have Dr. Reiser in Birmingham, and maybe we'll even get her into Florida to do an event with us. All right, but she could even boat on down here if she wants. All right, but let me go back to some of these other questions. So I don't know where I'm at here. Oh, I'm getting woohoos about me wearing 3 masks and having big ears. They have way to go, right? All right. And I'm not afraid to do it either. All right. So we did the one on that. We did the one on masks. Sherry about traveling. Oh, Sherry. So listen, when you travel, you just got to be safe. If you go into a public restroom, do not wear I'm going to tell you, I don't know about the doctor, but I'm going to tell you, don't wear a fabric mask going into a restroom. You're better off going in with a K95, right? Those fabric masks are for you to protect everybody else. It doesn't protect you. An N95 or a KN95 will protect you a lot more than a fabric mask. Yay or nay, Doc?
Yes, yay.
Good. All right. So that's what makes me travel up here 4.5 hours every week to do these virtual events. And I wear my K95s going into all the different rest areas, but I try not having to go. I have to invent one of those little portalets that I could just take out of the car and stand up on the side of the road and be all covered up and do my business and then get back in the car and just drive. All right. Anybody want to give me money for that? I'm willing to do it. All right. All right. Do we have another question? No. All right. We are done, Doctor. I want to thank you very much for being online with us tonight. Of course, I want to thank our supporters once again. You all can see them on the screen behind me. Sorry, I'm facing the wrong way. All right. But you see them on the screen behind me. And we would like to thank them for being part of this. And I would like to thank Dr. Reiser and her family for giving up her time to be with us tonight. And way to go. Yoo-hoo. And we hope to see you all back. By the way, everybody, I'll be back on the air tomorrow night. All right. With 2 MS patients, Damian Washington from Los Angeles and Dave Bexfield. And we are going to be on here doing an event. It's MS patients doing this talk with MS patients. It's called MS Patients Voices. And both Damian and Dave like to add a lot of humor to their day, and they bring it to others around them to make them smile. I try to do the same thing. We try to, keep the MS community as informed as possible with everything that we can. And we like to see them smile, have a giggle, have a laugh. I mean, you have to be able to do these things in order to stay healthy. So we're going to be on talking about things to do with each of our MSs, things that we each do for our own organizations, for the MS community. And we hope that you all can join us. And how to find it is to go to the MS Views and News website. Just type in www.ms as in Sam, V as in Victor, N as in Nancy.org. Go to the center column. We have all of our different events there for the month of March. By the way, we are doing 10, including tonight, in the month of March. And this is for MS Awareness Month. So we hope to see you on tomorrow night. And again, Doctor, thank you very much. And I'm going to say good night, everybody. Have a great night. Be safe. Wear your damn mask. Thank you.